afternoon, everyone. We are really honored to have Dr. S.P. Goswami here for the assessment of language disorder. Dr. S.P. Goswami holds a PhD in speech and hearing along with a PG DHRM and MBA in healthcare management. He is the first speech and hearing professional to receive the prestigious C.V. Raman Fellowship from the UGC, Government of India. As a visiting scholar at the University of Illinois at Urbana-Champaign, USA, currently serving as a professor and dean, research and development, Dr. Goswami has over 25 years of academic, clinical, research and administrative experience. His expertise spans aphasia, aging, neurocognitive communication disorders and policy development in disability. He has guided multiple PhD scholars, published extensively and has been recognized with the Dr. N. Ratna Award 2020 for his significant contribution to the field of speech and hearing pathology. Thank you.
Dr. Abhishek was supposed to come, so I'm just like in that football and all is there, no? You can take out player and you put it in player and all, right? So as per that I have been there, so I'll try to do, because this was available with me. I'll just talk to you about specifically when we looked into the adult disorders, okay? So basically what we are looking into is about these three things, right? So all, when you look into, these are the three things which we have been talking: cognitive, linguistic and the pragmatics. There has been different perspective about the pragmatics, but all these three things are interconnected. People have been talking about pragmatics. I have been looking pragmatics from, pragmatics comes under cognition, okay? Because why they are trying to say pragmatics is nothing but usage of the language, okay? Usage of the language, when you do it, when you try to do it, you definitely require what to say, when to say, how to say. That's what, and you will also try to take it from based upon your personal experiences, okay? So there are different schools which they put pragmatics, discourse, but under, I always try to follow this model because this is a better model which I like it, but you can vary. But when you see a person, you are going to look from these three things. But one component of language based upon one product, you will be able to say how bad is his cognitive, how bad is his linguistic and how bad is his pragmatic skills. It can have a reflection on this. So basically all these components, when you looked into cognition also, you looked into your recognition and understanding, memory, executive function, problem solving, abstract reasoning, okay? So what it indicates, look into these components. It is attention, perception, working memory, self-awareness, inhibition, judgmental, recognition and comprehension. Any test when you do it, like whether you do it at VAB, whether you do it through formal or informal test, indirectly or directly, it is going to tell you how good is his cognitive skills. Okay? Let us say when we do it, even in a VAB when we do it, you require all these components. Okay? If there is something wrong with these components, definitely your performance will come down. But then people say, okay, is it a cognitive, is it a linguistic, is it pragmatics? Yes. When you wanted to filter it, when you belong to different school of thoughts, when you belong to different disciplines, you might do it. But at the end of the day, what happens, it's his communication which is bad. Okay? And in communication, definitely cognitive will be one of the components. Okay? Like let us say when understanding is bad, when we say executive function, this is a classical example which we see in specifically in persons with dementias, persons with aphasias, right? So you will find several times these individuals shows perseverations, right? And perseveratory behaviors are nothing but these are inhibitions. When you talked about judgmental skills, like when you do into VAB also, when you ask him, point to this and this task, you require judgmental task. He has to judge it. Okay? So what happens, these are all inbuilt, problem solving, recognition and comprehension, which itself you have the component. So you can't differentiate it or you can't segregate it. These are more of complementary in nature rather than supplementary in nature. You also looked into the content. When you do the linguistics, you always look for semantics and morphology, syntax, as well as the phonological component when you looked into, however the division you do it, right? But every test, whenever you do it, it will give you a broad idea about this. Like when you talk to a person also, when a person is having a aphasia or a dementia, when you ask him what is his name, from where are you, how are you, why did you come, what happens, it will give you an idea, even with a general discourse, general conversation. Okay, you will get to know how is his phonology, how is his semantics, how is his syntax. There can be a person who may not use a sentence. Okay, his sentence structure may be bad. What we call as the SVO order might be disturbed, right? Or there may be a person who only talks at a meaning level. He might say, okay, book, food, good, okay. So what happens? There is some sort of syntactic component is affected in there, some sort of morphological component is affected. So even when you don't have a very structured standard tool, with a simple narrative, with a simple narration, with a simple conversation, you should be able to converge that, okay, which component is bad in these individuals. You looked into discourse, that's why pragmatics, we are looking into discourse, the cohesion, coherence and topic navigation, which is nothing but it's your social component. When you talk to something, are you able to maintain the cohesion, coherence from one paragraph to another paragraph, one topic to another topic? How do you navigate it also? How to, sometimes like when you read novels, when you watch a movie, right? Why do you watch movies? What is that good in that movie? When you say the movie is good, why?
Maybe the content.
Pardon?
Content of the story.
It's not the content, it is your discourse. Okay, it creates your inquisitiveness. How one step to another steps, you will have a curiosity. If you get those trailers, right? So trailer is what? It will tell you that there is inside some navigation is there. It creates inquisitiveness in your mind. That how the movie is going to move, right? That's how it will become interesting. Same thing happens with the discourse. So discourse is nothing but it's a flavor of your language. If you don't have a good flavor of language, definitely your output will be bad. So you can just say quantitatively there may be a good conversation. He might be able to use words, he is able to use sentence, but there is no discourse. When discourse is bad, that itself will indicate that the word what he is using, the movement what he is going to do from one paragraph to another or one sentence to another or one topic to another topic, it is disturbed. Okay, it is a disturbed. So that will give you a bigger picture that yes, his discourse is bad. Coherence, connection is nothing but it connecting from one line to another line, one paragraph to another paragraph, one conversation to another. How do we navigate it? All our patients will give you an idea, right? So it is important to assess this and what vocabulary do we use it? In which context we are using it? Simple pragmatics. Like all of us use bad words, right? But when you talk in a formal, you don't use it. But several times, what I am trying to say is this discourse, conversation and all, specifically persons with TBIs, okay? You will find that they will have a foul language, corporal alias, abusive in nature. There will be very good gentlemen, okay? Other than me, everyone is gentleman. Okay, so what happens? They abuse. So as a clinician, sometimes you also have to understand that his pragmatics is bad. His semantics is bad. Or you can just say what corporal area used, I always tell in the class, you can just say that these are paraphasic errors. Okay, these are neologism for him. Right? You should treat it as a neologism. But sometimes what happened as a clinician, we might think, oh, he is using such bad words. So what should I do? So, though we feel bad, but I think you should take that person as a person with aphasia. You should treat him like a patient. Okay, he is not doing voluntary. That there what will happen when you are talking about cognition, there is no inhibition in this. There then you can just say, okay, his parasympathetic and sympathetic system is the one which is calmed off now. He does not have a control. I am just trying to give you a simple example. With one conversation you can get several ideas how bad the system or how bad your neurological system would have been disintegrated. There is a possibility in that. But nowadays when we are looking into all those things, the trend what is changing, from medical model we are now moving to the biopsychosocial models. We are not looking into what has happened to the patient. He's having a stroke, he's having a TBI, he's having a dementia, XYZ, you name it. He might have. Now people are more focused upon this thing. Because of the neurological insult, how his activity and participation at work, at home, okay, with the family member, in the society is affected. That is what will give you a clear-cut picture of that patient. You might say, okay, his AQ score is this, his performance is so bad, all those things is perfect. But we don't measure someone's activity. We don't measure his participation. Because of the brain damage, he is not able to speak. Because of the brain damage, his cognitive skills are bad. Because of the brain damage, his mobility is bad. So that is what happens, his activities are bad. And as a result, in the society, his participation. He is not able to go back to the work. He is not able to go have a party. He is not able to go around, play something. Okay? So his participation in the society is affected. And that will decide how good, we use the term called as his productivity, his identity are the one which are at stake. Okay? At the end of the day, these are very important things for us. If his productivity, his identity and his dependency on the society is there, that directly reflects his activity and participation. But these two activities, because you cannot change what has happened in the brain. Right? Whatever damage has happened, stroke has happened, TBI has happened, you can go to the best of the best surgeon, neurosurgeon, whatever you do it. You cannot bring back whatever infarct has taken place, whatever, if there is a glioma, whatever they would have scooped it, whatever surgery they would have done, there is already a damage. They would only see to it that there is no further damage. But that damage, whatever has occurred, we cannot reverse back. There is nothing called as a reverse engineering in the brain. But what can happen? This activity and participation can be influenced by your environmental factor. If the environment at home, if the environment at work, if the environment in the country or in the society is conducive, the supportive, accessible, affordable, available. If that is there, definitely his activity will improve. Similarly, personal factors like his motivation, affordability of services, accessibility of services. If these things are there, environmental and personal factors are good, these can go directly influence the activity and the participation of an individual. I always give one classical examples. Like now, why do you come to the conference? Give me one example.
Update.
To update, right? So what do? This is your activity, you participate, right? But if the food is not good, stay is not good, right? Your environmental and personal factor, you don't have funds, will you be able to come? Same thing is here with the person, right? When this environment is good, if the hosts are good, they are quite friendly, they are supportive, definitely people will come. If the hosts are bad, people will say never ever go. The conference was bad. It did not induce enough activity in you. It does not make a difference in you. You did not enjoy. Same thing what happens in persons with stroke, dementias, TBIs, you name it. Any, starting from a non-degenerative to the degenerative conditions. So, what we say, whatever you can call as, it is the body structure and function which may be affected and individual's person environment. So what we are trying to say, it impacts the overall health, well-being and quality of life. See, health is not looked only from one angle. Because, I'm sorry, there will be people from medical fraternity, but health in medical fraternity, it is only from one angle. Okay? That is life. Breathe in, breathe out is the health for them. Okay? But believe me or not, that is not the life. Until and unless you have a quality of life, until and unless now people are moving to life satisfaction index, if these two things are not there, then that life is not worth it. Right? So we need to understand that with our treatment, with our approach, it's easy for us to see a patient in that state. Fine, for you, he's a patient. But for someone else, he's a father, husband, with a disability is very hard. It may be very easy for us to tell, okay, you have hearing loss, you have this, you treat him. But living with a person affects the quality of life of the family, of him, and there is a lot of emotional, economical burden as well as burnout is there. Please understand, that's what I am trying to say, that we need to understand, improve their well-being. It is more important. So don't look from that health tag. Health is a very conservative way of looking the person. We have to see the person from 360 degrees. Until and unless we don't have that approach, we will not be able to do it. So we should look some hope in every person. So you can assess the patient starting from acute to chronic, two different settings, emotional bouts, frequent crying, frequent shouting, screaming. There can be X, Y, Z number of issues. Don't see him that you look from a speech point of view, look from a language point of view, look from a psychology. That's a very conservative thought, I would always say. Because what are you looking? If you are going to, itself will be a biggest barrier for his communication. So, we need to, that's what we say, most of the time, due consideration to be given to person with aphasias, modalities and any other factors. That's not your primary job. Okay? Your job is to determine whether he's having aphasia, severity type using X number and profile. Profile, you need to look from these things beyond that. What he's able to do, what he's not able to do, why he's not able to do, what are those environmental barriers, what are those personal barriers, how do we take them further? And that trajectory, as a clinician, you can take a call on that. So that's what I talked about, all those things. We looked into the communicative, turn-taking, maintenance, initiation, repairs, all those things will be form of a pragmatics. So it's defined, basically they are looking into now, it is the evaluation of person's quality of life. Communicative interactions, role in larger units, and that's the basic difference what we see in South Asian countries and in the more developed countries we are looking. They are looking not from the condition point of view, they are looking from overall perspective. So before you start, always I have been saying, usually when the person is into ICU, okay, or when he is admitted and all, gain information and form initial hypothesis, initial referral, verbal information from your multidisciplinary team, medical notes, remember introduction and ending. Most of the time, I don't know about Nepal, and I don't know about other institutions. Series on Netflix, Good Doctor. There's a Dr. Murphy, right? You should watch that. That's a beautiful document. It's not because I have been watching it. Of late I liked it, but that's a beautiful documentary that how, as a clinician, you have to talk to the patient, right? They all introduce themselves, but here, I don't know about you, but in my institute, no one introduces. Whether I'm a cobbler, carpenter, who am I, right? Person should know it, you're a clinician. You are assessing him. Why are you going to assess it? And after assessment, what did you find? Did you wasted his time and then you said nothing, all is well? Then you are also inside the well, right? You need to make a distinction that what did you do? Why did you do? How much time did you spend? It is very important to hold the patient and caregiver with you because they are going through a lot of turmoil. We need to understand that part. And what will be your next step? People will ask you that how will be his recovery, how much time he will take. In behavioral sciences, we can't give any warranty. But we can always approximate that, give me some time, let me try this. So assessment tools, you have X number of tools, you use standardized and all those things which have got norms. But you can do screening and diagnostic. I will not talk about performance. Please tell me the time because I have bad pragmatics. Okay. So basically in a clinical setup when you do, I always try to tell that even if you don't have a structured standard tool, please look for a spontaneous speech. Ask him what's your name, how are you, where are you. If you ask a person that where are you, and if he says I am in palace, that itself will indicate that there is some sort of temporospatial orientations are disturbed. Right? When his awareness, do you have a problem? Auditory verbal comprehension, just simple task, ask him to point to 4 tasks, 5 tasks, whether he can do it. Can he point to the fan? Can he point towards the bed? Can he point towards his wife, husband, whoever it is? Repetition skills, simple. Naming is one of the strongest tool. Okay? If you can assess naming, it is one of the, means it can give you a lot of indications. I have been telling that, like if you do it in naming, you can do it at 3 levels. Confrontation naming, lexical generative naming, as well as phoneme fluency tasks. Okay? I was just talking to some of my colleagues yesterday also. We get a patient, I get a patient, she was a school teacher, very well, she was teaching mathematics or some science, but she was not able to remember it. She was forgetting in between. That was the only complaint that lady has. Around 45 years of lady, very good school teacher. She came, she says, I forget things. I can't name it, I know it what is there, but I don't remember it. Okay? So I said, okay, perfect. You do these 3 tasks. I'm just giving you an example. We did only these 3 tasks. Some of my PhD scholars and we were working, so they said, so nothing looks like. I said, fine. We just do a naming test again. We did phoneme fluency. We did lexical generative naming as well as we did a confrontation naming. Confrontation naming scores also were low. Okay, when you confront is nothing, present a picture and ask him what is this. That person gets a lot of visual cues and she should have been able to do it. Okay, out of 20 items, she could not even name 10 items. Then we did on lexical generative naming, her scores were around 2. Phoneme fluency, there was no score. So what could be the possible cause in this condition? She's a 45 years old woman, does everything, perfect wife. What could be the possible?
Insular glioma?
Pardon?
Insular glioma?
She's a pakka case of glioma, insular glioma. So I have to write it, tell him that okay, please can you just go for a neurologist opinion, and he happened to be known to me, so I said, sir, appears to have, she has a glioma. Okay, so then he calls me up and he says, did you see the scan? I said, I did not see the scan. Why I am trying to say is, it comes with your experience. If there's a lot of variable, and that's the strongest tool I am trying to tell you, can give you an idea, simple idea, you don't need it. So that's a perfect example we get into it, okay. Reading, writing, okay, sometimes people will not be able to do it, that's okay. But in case if they recovers, you can always do. Praxis component we have been talking. But what we have been doing is, this is what I know it will not be applicable. It's available in Hindi also now. So we have spontaneous speech, repetition, reading, auditory comprehension, naming and writing. Okay. What we do now is, we have given just 5 tasks. Under each there are 5 tasks. It's a very quick test. It can take maximum 7 to 8 minutes. Okay. Starting for auditory verbal comprehension, repetition, naming. We do it. Okay. Scoring is very clear. I always tell that whenever you assess these cognitive communication disorders, do not go for a binary choice. There is always scope. Okay. Give always more than 2 scoring that you can go for. We have gone 3, so 0, no response, partially and 2 correct response. So you can get a profile of these pictures, and these patients, what we have been telling, that there are maximum score you give 2, so 10 score means 5 questions are there. If he is a literate, you will get a score of 136. If he is not literate, you will get a score of 120. And based upon these scores, based upon these 4 domains, you will be able to say he falls under fluent category, he falls under non-fluent category, and if you are very good, you will be also able to say that okay, he is of Wernicke's variant, he is of Broca's variant, which variant he is, you should be able to judge it. But this will be your diagnosis which will change over a period of time. Understand that part, that every person with aphasia, every person with a stroke, every person with TBI, initial stages, he will have a recovery. How much recovery, how much the what you call as assessment is going to change, it will depend, but it will change. Then we all do it this way. This is gold standard for all of us. The reason why we do it in India is because this also tells us that what is the percentage of disability. It can tell me the percentage of disabilities. So here, how do you calculate it? It's a very simple task. Fluency and information content. You have a score of 10. So total you give a score of 20. But please remember, when you calculate AQ, CQ, you retain this score. You don't vary it. Okay? You just add it. But when you calculate type of aphasia, you are going to take only the fluency subsection. Okay? Auditory verbal comprehensions, you have got calculate AQ aphasia quotient and you calculate cortical quotients. The total score is 200. You have got yes no questions, 60 auditory verbal comprehensions. You have got 10 stimuli, 10 sections, 60 stimuli. Each score you give 1 and you get a score of 60. Sequential commands, 20 commands which are graded and you get a score of 80. Please remember one thing, based upon auditory word recognition task, when you put it into his visual field, you will be able to judge whether this person is showing some sort of neglect or not. Be careful about that. Several times you say, this person has responded only 5 items or 3 items. But you have not looked into whether he is showing some sort of neglect. There will be a visual field issues, he will not respond to that. So make sure that you have put the stimuli in his visual field. There will be individual. Specifically during the initial stages, you need to understand that part. Or if the person is having RSTs, he or she will have, TBIs will have. CVS may not have, but it can have also. So you be very careful about these things. Sometimes you need to understand that part. Second part, what will happen is several times when we assess all those things, this yes-no question and auditory word recognition are very important for us. Because when you do yes-no questions, these can be possibility of guesswork. So there is no cognitive taxing on this. If someone asks you, is your name so and so, he might say yes or no. Okay. So in that probability is when so MCQ questions, all of you would have written medical and all, right? Entrance. All of us would have failed in that, right? That's why we entered in this field, right? MCQ mein, right? MCQ, when you have multiple variations, cognitive taxing is required. But if binary choice is there, your probability of answering is 75%. Guesswork. Okay? So you need to understand that that's the main reason we have organized. Sequential command will give you an idea whether you can retain the stimulus or not. It will assess your cognitive skills. Okay, as the complexity increases, whether he can retain or not, it will give you an idea. But when you calculate for AQ, you divide by 20, but when you calculate for CQ, you divide by 20. I'll tell you why we do it. It's basically to convert into quotient. Repetition, you have 15 stimuli, you give a score of 10. This itself will tell you about that, okay, you can start from a word to phrase levels. It will also give you that whether he can repeat, he cannot repeat, and at what level he fails to repeat. So that will also give you about his ability to retain his stimulus. Another one important thing about repetition is, it's a very gold standard. If a person can repeat a task, okay, that indicates that the lesion lies outside the language zone. Simple task, close your eyes, that's a standard thing. But if a person cannot repeat, that means the lesion lies inside your language zone. Simple way of interpreting the VAP scores. It can give you a lot of information and then you can say that, okay, why this person is doing well, why this person is not doing well. If repetition is good, that means your core areas, your Broca's, Wernicke's, adequate fasciculus, all are intact. Okay, there is nothing wrong with that, but it has moved away. Or the areas would have started behaving like islands, that's possible. Naming, which I have told you, you looked for object naming, word fluency, sentence completion, responsive, and you get total is 100, you divide by 10, you get a score of 10. When we sum it up, reading and writing is also there, which you can do in case the people are literate, but if you can't, that's fine with that. And construction visuospatial skill is out of 100. Praxis component is 60. Several times you will say, okay, that he is having a praxis or apraxias and all. It will give you an idea about this component also. But you don't have to come here. Before itself you can tell him whether he is having apraxia component and all. Which section will tell you that he is not he is having apraxia component. All tests will tell you if he is having, he can have different types of apraxias, right? He can have a motoric apraxia, limb apraxias, oral apraxias when you ask him to repeat. That itself will give you idea. When you ask him to point, you need to understand, is it because of the paresis, because of the visual neglect, or is it because of some sort of apraxic component? He is not able to do it. You need to understand that. What I am trying to say is your tool will give you an idea about that. This is what happens. I was telling spontaneous speech 10 plus 10 you will retain. Auditory verbal comprehension you will retain 200 scores you get. Divide by 20 to get 10. Repetition is 100 divided by 10. Naming 100 divided by 10 it becomes 50. Because 20, 30, 40, 50 and you multiply by 2 you give a score of quotient. That's the cutoff score. And we say 93.8. Above that you will just say okay, either is a non-aphasics or is a clinically normal individuals when you can look into. So, performance quotient is based upon reading, writing and praxis as well as construction, which is nothing but you add it. It becomes 40. Here auditory verbal comprehension score you divide by 20 so that this becomes 60 and performance quotient it becomes. So, CQ is nothing but AQ plus PQ which will give you a score of 100. Please understand that this comprehensive score can skills. You name it, he can provide you an idea about it. Do you have time, ma'am? We are done? Okay, I was also done with this test. Okay, so based upon this, you can always label. So I was saying, more than 5, if it is there, put them into fluent. Less than 5, 4 if you are getting, you put them into the non-fluent variants. Okay, so these are certain tools, though there are several things which I will not talk to you about. I can't talk about this, but I will just sum it up because these are which you may not use it. We have another tool which we have developed it, which I will not talk to, but I will just sum it up in the last one slide where we have been to this. Yeah. So when you assess a person, several times we always need to interview professional workers. You can ask a neurologist, you can ask a neurosurgeon what happens, how is he doing it. You can ask a nurse how he is doing it. Look for the review notes. When possible person has a perception of his or current knowledge, most of the times we don't take a feedback that how he feels, how is he improving, what the family feels. It's very important to take their perception parts. Similarly, family members and others who have direct contact with person, because this will give you, we call as, like whenever there is a war and all the things, we say confidence building measures. Like now with what we call as Trump we are fighting, right? We are not building confidence building measures. We need to have this confidence building measures.
Welcome on stage Dr. Wasim Ahmed. Dr. Wasim Ahmed is a leading expert in physiology and neurogenic communication disorders, cochlear implants, auditory vocal therapy, craniofacial anomalies and laryngectomy rehabilitation. He holds a PhD degree from Manipur Academy and Higher Education and has published in high impact Scopus Index Journal, including Spinger's Nature. Dr. Ahmed has received multiple national and international Best Paper Awards and established the first speech and hearing institution in Northern Karnataka. He is currently developing a new medical college Best Speech and Hearing Institute at STM University.
Thank you very much, sir, for setting up the stage. Now that we have understood how we can comprehensively assess a person with possibly aphasia or many other neurogenic communication disorders, how do we start treating that person, or how do we start managing it? Because when my work comes into picture, I have worked in medical colleges most of the time, but I have stepped out of the comfort zone of being in a OPD and gone ahead to their homes to give therapy. So maybe I should thank Corona for that, because that made me step out of my comfort zone, go to the place where I can reach the person in their home setting, in their comfort zone, and believe me, the outcome is absolutely different. When you see a patient in the OPD or in the ward setting compared to that of when they are inside the comfort zone of their home with their families, the emotions are different, the performances are going to be different, and things will be very, very different from what we see in the clinical setting. So, Moving ahead, so as we understood that aphasia is not, just a brain disorder, rather we're looking at an acquired communication disorder which is basically focusing on four aspects, that is speaking, listening, reading and writing, and it is not basically a psychiatric disorder. So stroke either is due to a hemorrhage or is due to ischemic changes that have occurred, and any part of the region which is responsible for multiple aspects can result in different types of aphasia. So broadly you can put them under fluent and non-fluent types of aphasia. So I'll be more focusing on the non-fluent types of aphasia here and how we go about helping them. So as Sir rightly mentioned, we are not just trying to evaluate and put a score in terms of what is the language or speech motor disability, but rather we are looking at a bigger picture, that is the functionality, the limitations that the person has been facing, the life participation overall, and then comes the rehabilitation. So the idea behind the evaluation is trying to understand a person who was just like you and me before this incident. And once the incident has occurred, he has completely changed. And remember, stroke doesn't just affect the person, but the entire family. The entire family can stand still. Families can break. Many things go on. Especially, one point that I would like to mention is female persons with aphasia. They are the most worst hit is what I have understood. See, when a male person with aphasia is at home, the wife is expected to look after. But the same pressure doesn't happen the other way around. 90-95% of the times I have seen they have been left alone. Neither the parents want to take care of them, neither the husband or any of the children want to take care of them. Immediately there is a remarriage, family settled, this lady is forgotten. So it is not equal there. So it is not just about a language disorder, but far more beyond that. So how, when and where should I start? That first question. Your assessment procedure itself will give you that answer. You need to understand, okay, should I just take a random test and get the score and put a label? No. You take multiple cases of Broca's aphasia, each one of them will be different. You take Wernicke's aphasia cases, they will be different. There are no two cases that you can put under the same category. This is an idea for you to know which part of the language or the speech structures are we missing out here and what I should be intervening. But you need to focus on understanding where the baseline has to be set as a person himself, not just based on random scoring. So I'll just start with a few videos. So this will be a better way of explaining the therapy techniques, how we can go further. It will be in Kannada. I will translate wherever possible because the language structure, to some extent, Nepali, Kannada can be similar, I hope. If I'm not, it's very similar to Hindi, but to some extent, not exactly though.
Some Sanskrit word are similar.
Okay, so but the structure basically is.
Understand Kannada, they can't understand Nepal, so it is same.
Okay, so now we're coming on to this first case. I'll take you through a journey of this person. So we worked with this person for nearly 2 years. Okay, so he comes from a good background, educational background. He was working as a manager in one of a leading a garment company. Bodybuilder, was about to get married 2 weeks just before the incident. Everything shattered. One night he is at home, he has a hemorrhagic stroke. He wakes up in a pool of vomit and he is lying almost unconscious. Parents take him to the hospital. Quite a good amount of time has been lost because it occurred in the midnight. So only morning around 10 they realize that he has had a problem. So he comes up with this level of performance. This is a part of the ABA that I am doing. So listen to the sample.
What I say, you have to repeat it 3 times. Now you repeat it once. I will tell once. You will tell 3 times. Alright? Ashtray. 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 Living room. Articum. 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 Newspaper. 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 Banana. 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 Cigarette. Cigarette. Trigaman, Dramanan. Potato. Ataman, Andanam, Andaman.
You see, you get most of the factors here. So, VAB gives you Broca's aphasia as the diagnosis, but you also see that he has got apraxia in between. I'm not showing his face, but there's a very visible grouping that we are seeing, and the repetition is also affected significantly, and you can see the verbal apraxia, it is there. So, when we look at therapy techniques, we can broadly divide it into three types. One, the overall expressive language enhancement approaches, which is the visual action therapy, melodic intonation therapy, and script training. Then comes the word or lexical retrieval enhancement approaches, that is cueing hierarchy, semantic feature analysis, phonological component analysis, and then comes the syntax and pragmatic therapy techniques, which is verb network strengthening, VNEST popularly known as, training of underlying forms, TUF, mapping, therapy, sentence production, it is SPPA. What we need to understand here is, when should we use which technique? This is where most of the clinicians get confused. Now, should I start directly at this level of word, or should I start at the overall expression? What I have understood in my practice is, if there is a chance that you don't have to do much, for example, if you are looking at the staging of the stroke, whether it is acute level, subacute level, or it is in the early chronic stage, or it is going further, you need to start there. Maybe possibly you are looking at a case, but because when I see a case in the ward setting, most of the time it is just acute to subacute. Okay? Very rarely we get early chronic stages who directly walk into the OPD. Otherwise we are directly called into the ward. Look at the staging, look at the performance, and then decide where you have to begin. Now, if there is no verbal output or very, very less verbal output, this is where you need to start in visual action therapy, because this does not require the person to say anything, but rather you are trying to establish the basic communication platform there. After that, the most commonly used melodic intonation therapy. Melodic intonation therapy, unfortunately, is sometimes misused also. That means they keep on doing melodic intonation therapy for months together. In fact, I did meet one of the student clinicians in one of the colleges. I asked them, during the Viva, and they said they have been doing MIT for 1.5 years. And they were so proud that they made the person say 200 words. Now I said, are you helping a person with aphasia or are you training a parrot? A parrot can say a number of words. We don't speak just in words. We speak in sentences. We have a thought process. We have a way of talking. We have a way of expression. So communication is more important. It is not just how many number of words am I going to say. If the person is unable to transmit or generalize those words that he has picked up into real conversation, there is no point in therapy, no matter how many hours you do. So there is a time frame for each of these therapy techniques to start and to change your gears. That is, you will reach plateau with every technique, I am telling you. There is a time to start a therapy technique, keep evaluating, you will know that you have reached a particular plateau, change your gears, go to the next step. So, that means when I start an overall expressive enhancement techniques, I am recommending, from my personal experience, that once you are able to generate at least, see, for example, even phonemic or even, bisyllabic words on MIT. Start moving ahead. Automatic speech, easily able to generate his name or any other names on confrontation, or whether it is. So it is helping him to initiate the verbal response that you are expecting. That is the maximum you can do with MIT. You can put sentences, phrases, you can try with that. But it will not give you the speed that you are expecting until unless you change your gears and go into these techniques which are word or lexical retrieval. You can keep continuing MIT along with the lexical retrieval that will enhance the outcome. This will just give you help to head start in establishing the communication. So it is not a complete technique by itself. Okay, you can just start and say that yes, I have established a base of communication, I can take it further. So then, preparing client for specific treatment approaches is what the maximum these can do. Why? Because they have a very low generalizability. Whatever you do through MIT may not transfer outside the clinical session into real life. Cueing hierarchy. Many a times we don't understand what is the difference between cueing and feature analysis. When you talk about semantic feature analysis or phonological component analysis, it is not the same as queuing. What is queuing? If I ask you, what device do I have in my hand? What is this? Now you don't say anything. I start telling you, okay, this is an item that I use for presentations. I do this. I am giving the cue. It starts with per. I am giving the cue. The clinician is giving the cue. But when I extract the same based on question, okay, what do we use this for? Okay, how do I use it? Do you associate anything else with this? I am talking about a feature analysis that the person himself is doing. So that is what brings you to a queuing hierarchy. So queuing hierarchy goes in this direction. That means I ask the question, what is this? Without any cue, the highest form. No cue. Then goes to semantic cue, something related to this, meaning related cue. Then comes phonemic cue. Okay, it starts with the sound per. Okay, for a pointer, per. Then I may give a return cue. Following that is a pictorial or gestural cue. Then comes the repetition. What am I doing here is I am making the cue more and more redundant. The greater the redundancy, the less effort is required for that person to respond. So SFA basically is designed for self-queuing. Even we sometimes do this unknowingly. You remember I met that person who was there, who was wearing that yellow shirt, you know what happened, that fellow who was very funny, you remember that? What am I doing here? I'm not able to get the name, but I'm trying to get the features of that target word through my feature analysis and trying to come there. So what are we trying to do is, we are trying to activate the semantic network. That means there is an entire network around the concept. So everything that we see is not just a target word, it's a concept. If I say a dog, okay, dog itself is a concept. I can just ask you, name an animal, okay, which has fur, 4 legs and is domesticated. Some will say cat, some will say dog, some may even have sheep, whatever it is. But I keep going further. Okay, what is that furred animal, domesticated, 4 legs, 1 tail and can bark? See, now everybody tells dog. Why? Because dog has that salient feature of barking. So that is how you are trying to enhance that semantic network, and it is generalizing not only to the target but also others that is related to it. So it's a expanding network. So it is, as I said, it's more of a restrictive approach. That means even the non-targeted words, that means you targeted the dog, but there are so many different types of dog, different colors, different types. So you are going beyond just the target word, but you are going into a concept. So that is why it is, a restrictive approach, very good for generalization. So here you are basically trying to help the person to clue themselves whenever they are having difficulty in their normal conversation. I'll just take you across 2 videos. Okay, now SFA can be 2 types. One is for the nouns, another is for the verbs. Here the same patient, the one that you saw. What you are seeing here is I have kept a target word. This is the same chart that I have printed and kept it here. The target word is TV. Okay.
ಈ ವಸ್ತು ಯಾವ ಗುಂಪಲ್ಲಿ ಸೇರ್ಕೊಂಡಿದ್ದು?
I am asking about the group now.
ಎಲೆಕ್ಟ್ರಾನಿಕ್ಸ್ ಐಟಮಿಕ್ ಸೇರ್ತು.
He said it's an electronic item. What group it belongs?
ಇನ್ನೊಂದ್ಸಲ ಹೇಳಿ. ದೂರದರ್ಶನ.
So he says Doordarshana, or it's a kind of a television kind of a thing in Kannada, but he still not come to the word TV.
ದೂರದರ್ಶನ ಆಗತ್ತಿದ್ರಿಂದ ಓಕೆ. ಏನ್ ಕೆಲಸ ಮಾಡತ್ತದು?
I'm asking him the action now. How does it work?
ನನಗೆ ಎರಡನೇ ಪದ ಗೊತ್ತಾಗಲಿಲ್ಲ. ಚಾನಲ್.
See, the utterances are unclear because of the apraxic form.
ಚಾನಲ್ ಏನಾಗುತ್ತೆ?
I'm going in a clockwise direction. ಚಾನಲ್ ಏನಾಗುತ್ತೆ? ಓಕೆ, ಬೇರೆ ಚಾನಲ್ ಅಲ್ಲಿ ಬೇರೆ ಪ್ರೋಗ್ರಾಮ್ ನೋಡಬಹುದು. Because he was not getting the word, he said, I can see many programs.
ಚಾನಲ್ ಚೇಂಜ್ ಮಾಡಬಹುದು, ಅದು ಆಕ್ಷನ್ ಆಯ್ತು. ನಿಮ್ಗೆ ಏನ್ ನೆನಪಾಗುತ್ತೆ ನೋಡಿದ ತಕ್ಷಣ?
Respect that.
ಇದರಿಂದ ಏನ್ ನೆನಪು ಬರುತ್ತೆ?
Don't try to fit the word.
ಟಿವಿ. ಹೌದು, ಇದು ಟಿವಿ. ವೆರಿ ಗುಡ್.
See now what did he say? At the third step he got the word TV. He took the pause. He said, I don't want to tell all this. I'll come to the target, give me some time. But this did facilitate him to come at this point. But I don't stop here. I go further. So whenever you are doing SFA, most of the time clinicians what mistake they do is, you might get an answer at the first or the second level itself. They don't continue with the next process in order to go to the next. Similarly is for verbs, okay? The same way, but the questions, what are the gestures associated with it? Where do we do this? What tools do we use to do this particular action? Similarly is your phonological component analysis, okay? There we use the semantic features. Now similarly we are triggering the first sound and the last sound associates this in the same manner. So you are trying to get the target word, but also trying to give phonologically stimulable cues there, or a feature analysis for that. So what we need to remember, a few things. So keep the charts ready, okay, elicit responses from the client for each element rather than describing it yourself. That's what I said. You don't have to give the cue, you expect or elicit those cues from the person. That is, he should be able to do the feature analysis. Okay, you can give choices. Okay, you can give, as sir was rightly mentioning, rather than giving just two cues, you can give multiple cues from which the person can choose. Many a times you can give multiple picture cards which are related to that. For example, TV, I can keep a picture of sports, I can keep a picture of cartoon, I can keep a picture of a song or something happening, and he can still choose from that, or maybe something unrelated also. And he can choose, build that responses. Okay. So even if the person has set the answer in between, or if he is not able to elicit the answer, you may finish the entire process, tell the answer, and expect the person to repeat it. So you can put this in a chart to know if the person is improving with what. It's a very simple chart. What we have to do is, I have kept these 5 target words, and these are the cues that are kept in the hierarchy. Maybe, like for example, see this picture of car with a phonemic cueing or with a phonological comprehension. He said this on day 1, and here there was no response for eating, that is a verb, because verbs are more difficult to name compared to nouns. It will take some time. So probably you see that in different levels the person has responded on day 1. I will do the same list the second day also. It might remain the same or it might move this way. That means the person might remember what was taught to him and he remembers it well. So I'll keep doing it to such a level that on 3 consecutive sessions this list comes into, or this particular target comes into no clue on 3 consecutive days. That means it has stabilized and it will more chances of it getting generalized there. So what do we do next? Make the person say 30 nouns and 10 verbs. This is my recommendation, there's nothing, so my personal list. So 30 nouns, 10 verbs. What next? You don't have to wait for it to go to 200, you can go to the next level, that is the sentence generation or sentence building task, that is coming on to next. So when should we discontinue something? I told you, something needs to be started and something needs to be ended at one point. That is, now client can now self-cue to retrieve a word or during conversation. But one thing what I have felt is that SF and PCA will continue even later on, but not as intensively as that we are doing in the initial sessions. You need to move to sentence building task, and as the person has a difficulty finding the cue, use this technique. When the latency of word retrieval, that means you saw in that he was taking around 30 seconds to get the target word. Now the latency has started reducing. So once it starts reducing, that is also an indication that you need to give the person a component analysis or a feature analysis every time. Only for new words, maybe when the person is unable to say, go back to this. And now he is convenient in retrieving wide range of words. Now that brings us to the sentence generation task, that is VNest. So VNest basically was for verb retrieval and word retrieval, yes. But it also gives one step ahead to generate sentences. I try to put it in very, very simple manner because it itself comes with a big manual. You can go through that. Even there is a cheat sheet for VNest. You can see how to use that. But I'll try to put it in as simple as possible here. See, when we talk about verbs, it's not the same as nouns. Verbs, most of the time, do not exist on their own. They act as the fulcrum of a sentence. That means, verb is the core and there are other nouns that come along with it to form a sentence. Okay, if I say running, who is running? That is an obligatory argument. Argument is not that me and you are arguing. A noun which is definitely going to be associated with that verb is called as an argument. There could be two arguments. Now you can ask me, sir, boy running on the road. On the road is not very important. It's called an optional argument. So what if I have to give any different definition of a verb? Run. Who is running? Similarly, give. Who gave to whom? Two arguments. 3. Pouring. Somebody is pouring something onto something. If I just stop it at 2, okay, boy is pouring water. Where? On the head, on the shoulder, on the floor. Now this becomes obligatory and optional verbs. So, when you choose verbs in VNest, we may think, what is the big deal? We'll just download a list of verbs and choose any verb for therapy. It doesn't work that way. As the number of arguments increases, the verb valency we call that, as it becomes deeper and deeper, it becomes more and more difficult. So initially you need to start with 1 argument verbs, then move on to 2 argument and then to 3 argument. Today you do run, the person does well, tomorrow you take a 3 argument word, okay, chase or this one. This session he did do well, so you are confused. Yesterday he was good, today he is not doing well because you did not choose the word properly. That is where the clinician made a mistake, not the person. You will say, oh, you are not practicing well at home, you should do this, you should do that. Family, what can they do? Looking after that person itself is a big task. So if the people around him understand this basic concept, when I am talking about any action, how should I conveniently make the person perform? Today he is able to perform at this level, tomorrow I will take him here, then further here. So you slowly build on to the structure, okay? So, as I said, see, there are many more. I am just highlighting on these most common things. Agent, who is doing it? Patient, on whom or what they are doing it. Location, where are they doing it? Time, when was it happening? Then comes manner, how was it happening? And most importantly, the reason, why was it happening? And it goes in this direction of hierarchy. The way we saw the queuing hierarchy, okay, we are also seeing the hierarchy for how we need to stimulate the verb with its arguments. If you forget this, first of all you give a running. Why was he running? Gone. You have gone to the most difficult part. How was he running? Now how do I show? Now you need to go further. So you can build that sentence to what level? A boy was running, okay, on the road in the morning, okay, very fast, and because he was late to school. Now VNest helps you to develop this. But what did I do now? I did not put the functional aspects much here. I just gave you the important aspects. What did I say? Who did? Boy ran or boy run. Okay? Maybe along with a girl. Location? On the road. Time? Morning. Manner? Fast. Reason? Late to school. This is the maximum you can expect to develop in a VNest. But the actual grammatical aspects are not much emphasized when it comes to VNest. You need to go further for syntax-based tasks there. Just give me 5 minutes, please. Yes, I'm almost done. You understand? So VNest doesn't give you grammatical depth, whereas there are other tests, that is SPPA, TUF basically. So I explained this already. Let me come here. The steps are very simple for VNest. Initially you just generate what it is. That is, if I keep maybe I'll explain it in English itself. Who did what? So the verb is in between. Keeping the verb, I am just generating whos and the whats. Then I go further. I make the person read out whatever that he has generated. Okay. Step 3. If that is the sentence, boy running. Where was he running? When was he running? Why was he running? So like that, 6 sentences are generated, followed by semantic judgment task, where you can give correct and incorrect sentences and ask the person to judge. Then repeat the verb independently what we are practicing, one verb at a time, and then comes the one sentence that he has generated. So this is what VNest does. Now I'll skip the video because this will go into So after that you can go into other techniques once you have generated. So if you do not have TUF or you do not have SPPA in your language, it's okay. But response elaboration training can be taken further in order to expand the responses. Okay, he was not able to give you bits and pieces in a structure, now start putting in things. So this is, okay, after nearly one year, 2 months of therapy, I just want you to listen to how he is speaking, the same boy.
Namaskara.
Namaskara.
Good morning.
Good morning.
ಹೆಂಗಿತ್ತು ವೀಕೆಂಡ್?
Weekend exercise ಮಾಡತಾ ಇದ್ದೆ.
It's a full sentence. I was exercising this weekend.
PV ನೋಡ್ತಾ ಇದ್ದೆ.
I was watching TV. Now the breakage of the sentence is because of the apraxia and not because of the language component.
ನಿಮ್ಮ weekend ಹೆಂಗಿತ್ತು?
ನನ್ನ ವೀಕೆಂಡ್ ಚೆನ್ನಾಗಿತ್ತು.
Now this is where I wanted your attention to be. He asked a question. Persons with aphasia, most of the time, don't ask questions. They will respond to what you ask. Why don't they ask the question? So this was the question for my PhD. Why persons with aphasia don't ask questions? You know why? Because questions or interrogatives are one of the most complex sentences that needs to be trained again. That's why the person loses the ability to form a sentence which ends with a question. So there are different types of sentences. There are declarative sentences. Okay, there are negations. So when it comes to interrogatives, it is one of the most difficult part. So I'll just move ahead. I will not focus on this. Yeah, I told you. The shortcomings are, it doesn't go into the grammatical depth. You need to go for other techniques there. So as I said, these are the techniques for sentence generation. In English, yes, definitely it is available. But the problem is, you can't directly translate them into your native languages because of the difference in the structure of English as well as your native language. Same thing happened in Kannada as well for us, because Kannada is an agglutinative language. We had to reinvent the wheel with the linguistic principles, and we had to come across. So there is this one. Yeah, this was one of the tests that we developed. We developed it as a part of an assessment and a therapeutic tool that gave us the understanding of word processing, comprehension and expression, argument processing, comprehension and expression, and the sentence processing with 6 different types of sentences, including questions. So there we use the same platform in order to train the person at the first level, that is to start developing simple sentences, and an advanced module where it goes beyond just simple sentences into grammatically rich sentences. So technically, the natural language processing is being highlighted. So there is one more technique, SCVTR. So this is one technique that one of the PhD candidates of Goswami sir has developed this in 2020, which is very similar to the Venus part. This is one of the first techniques that came into existence in early 2020s, which gives the person an idea to move ahead of just word retrieval. So not only does it help in verb retrieval, but to start generating sentences. So 3 years later, during my PhD work, it went ahead where it is not just sentence generation, but also trying to understand, the advanced syntactic features that needs to be added. So as I said, natural language processing, retaining or getting it back is one of the most important aspects. Don't ever feel that if you have achieved 200 words, 500 words, even 1000 words, if it doesn't transfer into real life situation, it's absolutely no use. The generalization has to occur. The person has to be comfortable with whatever that he has achieved and try to use it naturally. How far can we go? A similar case, exactly a similar case that I was trying to show you. This boy is one that intrigued me to the maximum and made me stay in aphasia. He is now running an auto rickshaw. Auto rickshaw is a taxi, okay, 3-wheel taxi. Okay, it was sponsored by my boss at that time, Dr. Radhika Poya. So she sponsored it. The company altered the auto in such a way that he can drive with one hand. So he is living his life independently. Okay, so one of the leading newspapers, Times of India, covered it that time. Okay, no matter what the difficulty was, this smile never faded. So whenever I feel low, I go back and read this article once again. My life can't be as bad as this guy has, grown over it. And it took him 3.5 to 4 years to achieve that level. So now he has, I won't say that he has completely, reverted with all the language functions, but the language that he has recovered is enough for him to be functional, earn for his life. His wife had deserted him, he won her back. So now that is rehabilitation for you guys. Thank you very much.
Quickly, if you have any questions.
If any questions, you can please reach me at this number or contact. Thank you very much.
Okay, I think we can go with the other talk.
And post-laryngectomy rehabilitation, an academic lecturer for ENT-HNS residents. She has also published research on language development in English-speaking children and speech and hearing assessment comparison across languages. Mr. Kali is an active member of SHANCON and Stuttering Association Nepal. Ladies and gentlemen, please join me in welcoming our chairperson, Ms. Santa Thakal, to take over this session.
Professor of Clinical Psychology, Department of Neurosurgery, PGI Mar, Chandigarh, India. Mr. Dr. Manju Mohati is a clinical neuropsychologist specializing in developmental disorders, cognitive assessment and rehabilitation for neurological conditions. With around 90 publications and multiple awards, including international travel bursaries from WCM, CSIR and ESOC. She has served as Secretary General of the Indian Association of Child and Adolescent Mental Health and is a frequent speaker at global scientific forums. So as an SLP, we know that cognitive aspects are integral part of the speech and language development. So I think this session will be most effective for all of us who is working on the child language. So I just like to hand over the mic and the floor to the ma'am. Ma'am, the session is yours.
The chairperson has already introduced me. So today we are going to discuss speech and language delays are the most common developmental concerns during the early childhood. They may occur as a primary disorder or as a broader neurodevelopmental disorder such as association affects the quality of life. So let's understand what is the relationship between speech, language and cognition. As Dr. Goswami has already told you about this, cognitive abilities help in acquisition of language and language supports high cognitive functions like working memory, executive functions, etc. So now why it is crucial to do the cognitive assessment? First, it helps us to differentiate between whether it is a purely language disorder or it is associated with any other developmental delay. And then on the basis of the cognitive limitations of the child and on the basis the intervention planning is done, whether the child will go to a special school or child will go for the speech therapy and where to place him in the school. And even the prognosis is also dependent on the cognition. If the child is cognitively adequate, then there are more chances he is likely to recover more quickly. Though it is essential, but it is not easy to first of all administer the test, and then even if you have administered it, it's very difficult to interpret. There are so many difficulties which are encountered like linguistic bias, behavioral and attention difficulties, cognitive delay versus language disorder, cultural and linguistic diversity, and limited norm-reference tools. What is the linguistic bias? These are the most commonly used measures. Visual intelligence scale, all the visual scales are the widely used because they are comprehensive and they give you a understanding of the several domains. But the drawback is that most of these rely heavily on the verbal comprehension and how well the child can express. So if the child's performance is low, so it leads to risk of misinterpreting these language limitations as cognitive deficits. Let's have a look at the risk score. It gives you scores on the working memory. It is digit span, letter number sequencing, though it is numbered, so it has a low load on language, but still it has a verbal component. These two, perceptual reasoning and processing speed, they are totally non-verbal part of 10, but the limitation is that a full scale IQ is the average of all the subdomain scores. So which, if the child scores low on verbal comprehension or working memory, he may get a low IQ. So then it will become difficult to determine whether it is the language disorder or it is the intellectual disability. Then it is very common that the children with speech and language delay are also presented with behavioral and attentional difficulties, especially if it is associated with ADHD and autism spectrum disorder. So they may have short attention span, hyperactivity, social withdrawal or anxiety and sensory sensitivities, which interferes in test engagement. These people are more likely to take more time, especially if the tests are timed. So it will affect their scores, which further complicates the validity of the assessment. And one of the major clinical dilemma is why the child is performing poorly. Whether it is a pure speech and language disorder, it's intellectual disability, a global developmental delay, or it's a part of the autism spectrum disorder. So early diagnosis becomes difficult. So mistaking one for the other can lead to inappropriate planning of interventions. Each culture is different. So each culture differ in the communication styles. The tasks which we are using may not be familiar to the child. So they are going to affect the performance. Then the children with multilingual or bilingual families are likely to perform poorly if they are tested in some other language. Suppose the child speaks Nepali, he is more fluent in Nepalese or Hindi. If he is assessed in English, so it is going to affect his performance. So, and standardized tools always may not be culturally and linguistically appropriate. So there will always be a risk of misdiagnosis or overdiagnosis of delay or disability. Then there is scarcity of non-verbal and minimally verbal cognitive assessment tools. And there is also lack of normative data, especially for younger children under 5. And many of the tests are either developed in Western countries or in some other parts of the region. And if you use the norms developed in that particular region or that particular country, that will not give you an accurate idea of the problems. So there is need for more developmentally appropriate tools which have less load on language. So what should be done? How can we overcome this? So we should be using non-verbal or performance-based assessments which focus on non-verbal reasoning and visuospatial processing. They may be more appropriate for children with language impairments and can be used across all ages and cultures. One of the common measures which we can use is Gesell's drawing test. Gesell's drawing test is a very simple test. It's just the child is expected to copy very few simple figures like circle, cross, rectangle, triangle. So accordingly, you can give to the higher, little more complex figures. Sapling forward, and it can be used, the Gesell drawing can be used with very from the 3 years old child, but even if the child is able to make a straight line or a horizontal line or a vertical line, it can be used with a 2-year child also. Then segment combo test is another test which can be used with the younger children also. It basically measures your perceptual ability and your concept formation. This is a simple test where a board it's an apparatus where there are certain, but the child is expected to fit a block into their respective holes. Then colored progressive matrices, I think that you all are familiar, which is used in, which is a part of the WABs also. So it measures your exact reasoning, but it can be used only the child with more than 5 years of age. Then there are certain other tests, Kaufman assessment and lighter international performance scale. So when this is the formal test we are doing, but even we can use the naturalistic observations like play observations, functional and play-based assessment, which can be structured or unstructured, and this will give you a valuable information about his problem-solving abilities, his memory, executive functioning, his planning skills, etc. Parents should be made an important part of the assessment. So, a detailed interview of the parent is very important. You should be asking about his developmental milestones, his functional communication abilities. Not only the simple how much he can speak or how many words he can use, but how much functional communication abilities. And how adaptive functioning, like how well he can adjust to his environment or his independence in each type of skills. One can use the scales also. There are few structured scales, but they need to be used with caution, like Wineland Social Maturity Scale and Wineland Adaptive Behavior Scale. So this information from the parents helps us to interpret the findings more accurately, as it needs a multidisciplinary intervention. So the collaboration between speech language pathologists, psychologists, neurologists, educators is a must. Speech language pathologist assesses the communication skills, psychologist's role is to do the cognitive assessment, and neurologist rule out the medical or neurodevelopmental causes. And obviously the educators play an important role in, they provide insight into how well they can learn in the class and the classroom behavior. So all these assessments, when we do all these types of assessment, sometimes we feel it's not giving the exact information because we are just assessing and doing. So the main thing is, because most of the children, they do not perform well on one or the other tests. So what is the method? So we should focus on the child's learning potential and responsiveness to the intervention rather than his performance at one particular time. So he should be tested first, then he should be provided training, then he should be retested again. So this procedure should go on till we reach our goal. So when standardized test fails to capture abilities, so it may help us also to monitor the progress. So now let's understand it through the various case studies. So I'm presenting the findings of assessment results of the various diagnostic groups, which is speech test, these five groups. So the test we administered were Wechsler's Intelligence Scale for Children, Gettel's Drawing Test, Sepin-Fomburg Test, Color Progressive Matrices, Wineland Social Maturity Scale. So it's a parental interview. So the first child, it was a 13-year-old boy who was studying in 4th standard in a normal school. Though all the developmental milestones were delayed, he had no family history. So when we administered all these tests, so on the wrist, as you see, he has a low scores on each and everything. But not only on the few aspects, but he scored low on all range from 60 to 68. So that we could differentiate that it is the intellectual disability because it's a global delay. A 10-year-old girl who was studying in class 3, her except speech, her all other developmental milestones were no family history. And when we assessed her, you could see her scores. She scored low only on the verbal comprehension and working memory. And all other scores were in their average range. However, she also scored low on violent session.
I'm sorry to interrupt, the allotted time is up, so.
I'm just going to wind it up. Just 2 more steps. So, VSMS, because there is a communication part also, that's why she scored less. So you can have a look at a score on speech and language delay with a comorbid diagnosis of ADHD. So except on these 2 which has totally verbal also the processing speed. And attention deficit hyperactivity disorder, all language components were adequate, only the score was low on working memory and processing speed. Similarly, autism spectrum disorder also scored low on verbal comprehension, working memory and processing speed. So this is the comparison. You can see how it comes out. So to conclude, we can say the cognitive assessment in children with speech and language delays requires careful selection of tools, strategies, interdisciplinary collaboration and consideration of child's unique profile. The challenges are significant, but a tailored approach can uncover cognitive strengths and guide effective interventions. So the take-home messages: avoid dependence on language-based assessments, interpret results with caution, considering limited language ability, use alternative methods like non-verbal play-based assessments, understand the findings in the broader developmental context and involve family members in the assessment. Thank you.
Cases in clinics, private or in multidisciplinary team approaches. Thank you again on the behalf of the International Conference and Organizing Committee 2025. Thank you.
Ms. Santa Takal to hand over the certificate to the speaker of the session, Dr.
And thought-provoking session. Please join me in welcoming our moderator, Mr. Sabin Sarmadawarti, Hearing Health Alliance IOM, consultant SLP at Neo Health Clinic and Frontline Hospital, and is the clinical director and co-founder of Bhaktapur Neo Clinic.
Let's give a warm, enthusiastic round of applause as we invite our moderator to take charge of this exciting discussion.
Panel discussion is autism spectrum disorders. So we'll mostly discuss, as per the theme, we'll discuss about communication and social integrity, how there are a role across the discipline, let's say cross-sectoral roles. For that, I would first like to invite Professor Dr. Beena Prajapati. She's the Chief Consultant Pediatrician in Kanti Children's Hospital. She's trained in pediatric neurology. Hereafter, I would like to invite Mr. Samit Kumar Katila. He is the President of Nepal Physiotherapy Association and an advocate for education-related sector of autism spectrum disorder. He also holds his master's degree in education for special children. Now I'd like to invite Ms. Neelam Lama. She's a seasoned speech-language pathologist. It's almost a decade she has an experience in working in EST. She's now the co-founder of Bloom Park Clinic. Now also I would like to invite Ms. Ganga Guru. She is the General Secretary of Occupational Therapy Association of Nepal. She is also the co-founder of Bloom Park Clinic, and she's advocate of neurodiversity affirming practices. So forms a team, multidisciplinary team here. So our theme of discussion, obviously we are adhering to the theme, the cross-sectoral roles in communications and social integrity. So in this regard, I would first like to ask Professor Beena Prajapati. She has been the consultant in Nepal government for more than decades. So she has been working in Kanti Children's Hospital. It's a focal point for pediatric cases throughout the country. So she has been into this field since so long as a chief consultant. So I would like to ask her, Madam, before a decade and now, we have seen a lot of children coming to you with the developmental disorders. So what is the trajectory shift? I mean to say, the number of cases you used to see, a pattern of the disorders or the syndromes you used to see, not only the autism but the neurodiverse cases or developmental disorder cases. Then and now, if you compare as a focal person for this sector, especially in the government, what is your view in this?
Regarding that, today's the main focus is autism, but in my neurology OPD, till now also, the 2/3 of the cases are the developmental delay. That means cerebral palsy. Developmental delay can be caused by different things, but still the most common cause is 2/3. But with this development of new era, with genetic diagnosis and all, we are getting lots and lots of genetic syndromic developmental delay. And when we add on, this because of this genetic era, we are finding lots of common genes which are responsible for the developmental delay and also responsible for the communication problem like autism and ADHD. And lastly, again I say globally, after the COVID, we are getting lots and lots of cases with communication and social problems. Whether it is autism or not, but we are getting lots and lots of cases, especially the children with social and communication problem after the COVID, after the corona. Okay, thank you.
Thank you, madam, for your insights. Definitely, as madam said, especially in not only in Nepal, if you consider the prevalence rate in the global scenario, we have it always has been increasing now. So yes, a lot of people ask about the causes of this. A lot of parents ask about the causes of this. So what I have been saying is, it's all about the multifactorial. Causes are always multifactorial and always, it is always intertwined. And if it would be, there is always a difference between causes and risk factor, let's say. Just like we say that smoking causes cancer, but it doesn't mean that every smokers develop cancer. Similarly, in autism, developmental disorders, there are certain risk factors, but which might show the likelihood of manifestation of social communication issues and all. So also not only in the cases approaching to the tertiary care hospitals or government, also there has been shift in the recent days, the trajectory shift in the treatment and management approaches as well. Let us say early back then in 1980s, 1900s, mostly it used to be dependent on the discrete trial training, LOVAS approach, and mostly the compliant basis approaches. So now we have a lot of neurodiversity affirming approaches here. Now this question goes to Ganga, occupational therapist. So how do you balance between your neurodiversity advocacy and making the child very much so much functional that his self-regulatory behaviors, so-called steaming by someone, steaming earlier. So if these are there, some of the advocates consider this as self-regulating behavior. Children must have freedom to do this, but others say that it has to be stopped. So I know you are so much into this neurodiversity affirming practices. What is your view in this, and how do you tackle your how do you tackle the queries in this regard, and especially when the extreme behaviorists say that I remove this thing like by hand swipe, and the parents get so happy that wow, it's removed. So how do you deal such situation and with your views? Just share me your reflection on this.
Just got an announcement, and I would like to call Dr. S.P. Goswami and Sarah Rixby to make your way for the judging of the posters. Besides, please continue.
Firstly, I'm glad that I am known as neurodiversity affirming therapist. I like the sound of it. Our goal while working with children is always functional independence. Everybody would like to keep that in mind while working with children. Having said that, all this diversion from compliance-based approach to now really neuro-affirming approaches like DIR flow time, strengths-based approaches. Why are they different, and why do they mean better for our children? Is because their lens is humanistic, their lens is, the basis of them is that every human being is different, has different sets of thoughts. We are neurodiverse in our ways. And to be able to embrace that in today's time where so much research is available, so much advocacy have been done by autistic people themselves, us not listening to them, us not listening to what they are saying, that how compliance-based approaches are harmful to us and have been traumatic, is inherently sad for us as professionals if we are not updating ourselves. Having said that, when we are taking a relationship-based approach or a strength-based approach with our children, we're not just affirming to their neurodiversity, we're also embracing the fact that we all have unique ways of being, and normalcy is, and what is normalcy? Everybody thinks in their own way, everybody regulates, processes in their own different way, and we all have different sensory profiles. We all have different emotional profiles. So if we do not keep them in mind, it is equivalent to us being in the era of when there were no better approaches to take, but when there are so much available now, it just makes sense that we are also being more, we were giving our children the grace of being different, embracing that they are different, and then helping them thrive as professionals. Functional independence comes from supporting a child by understanding their sensory profile, by understanding their emotional profile, by understanding how they learn, by making sure that we are using visual supports or routine or predictable transitions whenever they have difficulty in executive functioning, right? So, in short, sometimes the pathway to our goal might be long, but a humanistic approach is always the best way to reach that goal.
Thank you, Ganga, for your insightful answer. Now we have with us Mr. Shamit Kumar Kahila. He is the president of Physiotherapy Association, and also he has done his master in education. Am I right? Education, what's the name? Like early education? Inclusive and special education. So with this regard, I would like to ask, and he's also managing a special school with around 100 children children with disabilities, especially autistic children. Also, he has been managing different centers across. And wonderful thing he has been doing is the implementation of IEP in the school. So I ask him, how difficult is it to coordinate? Because this is not implemented, this hasn't been implemented in a lot of places, IEP, but you have been doing wonderfully. It is implemented in the special school that you are running, and wonderful coordination is there across the discipline. Teachers, you have been managing the rehab professionals so well, despite being a physiotherapist. And so, what challenges have you faced when you implemented IEP? You counsel the children, because it's a new concept here. It's not easy to manage a special school. So share your challenges, your strength there, and maybe you can give some input in a very short, concise way.
Thank you, Sabine. I think Sabine knows that whenever I hold a mic, I speak for quite a long time. But I can understand the schedule is a little too late, so I won't be taking much time. So about the challenges of IB, I think the first thing which is very important to understand is the neurodiversity and the diversity. There can be diverse student in a class in terms of language, in terms of culture, in terms of any other thing. So even that can lead to some kind of challenges or problem within the class. But when we say about neurodiversity, it is always indicating some kind of medical conditions for which the child may need additional support. And in an international practice and evidence-based practice, any children under any diagnosis who are not 100% neurotypical children for an academic or anything that is taught in the school shall need IEP. And it is difficult in country like ours, because when we say in policy level, there is already a document of IEP, which is an assessment document, and that needs to be implemented by the teachers, special educator or something like that. We have inclusive educations, we have special educations, and we have mainstream schools that are enrolling neurodiverse kids as well, but we do not see the implementations of IEP. IEP is the basic foundations of any schools that has neurodiverse children, which says about the conditions of the children, the present level of the children, what kind of additional support the children might need. So I think, first of all, the identifications or the awareness of IEP for neurodiverse children is not known in the country. There are centers that are now implementing. So the awareness has to be more about the IEP and the IEP team. So internationally, our evidence-based practice says that there has to be psychologists, occupational therapists, speech therapists, special educators, teachers, parents, either side is set in that. But we do not have this human resource in all the centers. But there are always alternatives to that. A teacher can be educated about that and can be trained to do the IEP assessment and implement. So at the moment, it is very challenging to have the team members, awareness and the implementations at the same time.
Thank you, Mr. Samir. So thank you for your insight. It's very valuable because you hold a lot of experience in this. Now I'd like to ask Ms. Neelam Lama is an experienced SLP in autism sector. So I just want to ask her to say give message to the other SLPs, young SLPs, just by your experience. Just what about your experience?
Thank you, Sabine. And first of all, thank you, Dr. Bina. I'm very, very fortunate that I'm sharing this panel discussion with my mentor. She's my mentor since 10 years. I've started my career with her only. Talking about my experience, definitely we meet so many parents. I'm working with the children since 10 years. Mostly I have been seeing autistic children only. Definitely you all have also been working with autistic children and you know how parents come. First of all, counseling plays a very important role. When the child comes with his or her parents at the clinic, I think counseling plays a very important role. If you work 80%, if you work in counseling, if you know how to talk with the parents, I'm just saying my junior, I know definitely seniors are also there. First of all, what parents say is that my child is definitely, he's fine. If he speaks, everything will be fine, right? So what I do is I try to explain them what is speech, what is language and what is communication. What is their question is like, if my child speaks, everything will be fine. But they don't know the difference between speech, language and communication. Definitely we work in communication, right? But if we ask why you brought your children to speech language therapy, their answer will be because they have not spoken. I need to you need to work on his speech, but we are working on communication, right? So these small things we need to explain. Definitely we need to work on child strength, like what Dr. Ganga told. Child-led therapy is very important. We need to have connection with the children. We need to have connection with the parents. And not on the weakness only. We need to build up the connection. And we need to work on strength rather than correcting the differences. Thank you.
Thank you very much. Thank you very much, Ms. Neelam Lama. Now I again get back to Dr. Bina. So Dr. Bina is one of the leading senior in this pediatric neurology sector. So she has come across a lot of cases of epilepsy, just about the comorbidity of autism and epilepsy. If the epilepsy brings some social communication issues, is it the manifestation of epilepsy seizure, or it's a comorbid? We need to diagnose AST and epilepsy separately, with AST with comorbid epilepsy. What is your thought on this?
This is one of the very important questions, and epilepsy is my best topic. So in autism there are lots of comorbidities, but among them epilepsy is quite common and quite important. So what I will say is, in short, if the child has epilepsy, can also present as an autistic feature. So there are certain syndromes, epilepsy syndromes, the child has epilepsy but the child presented with autistic feature. I will not say autism but autistic feature. So if you treat the epilepsy, these are the epileptic encephalopathy. What we say is a bad type of epilepsy. If you treat the epileptic encephalopathy, the child might improve. The child will improve. But on the other hand, the child with autism also will have co-occurrence of epilepsy, because the prevalence of epilepsy in autism is quite high than the same age normal population. So it's around like 10 to 50%. And this epilepsy is quite common on the younger children, that is preschool, 1 to 5 years, and bimodal presentation, that is on the adolescents, 11 to 17 years. So, but lots of researches are still going on. They say that co-occurrence is because of the sharing of the causal genetic and environmental factor in both the epilepsy and autism. It is not that epilepsy is causing autism or autism is causing the epilepsy. So there are lots of, more than 100 genetic mutations. The common one is KCNQ2, zone epilepsy, SCN1, SCN2A. These are quite genetic mutation which is found in the autistic people also and which is found in the refractory epilepsy also. So, and again, some of my parents, the parents of autism, they come, we are doing therapy for such a long, but my child is not improving. Some parents come with, my child is rather regression. And my child is, previously there was, speech was predominantly problem, now the cognition is also problem. So these are quite things which you have to evaluate, might be this child is having subclinical seizure. So it is mandatory to do the EEG, and if you treat these manifestation can improve. So that's why these are the things. If the child does not improve with intervention, if the child regresses, if the child's severity increases, then we need to evaluate for the epilepsy.
Thank you very much, ma'am, for sharing your knowledge and experiences in this sector. Now, we just take forward a topic for discussion, a very brief topic. The topic for the discussion now is the treatment approaches. Like, we are focusing on multi-sectoral sectors of autism. So one of them is social integrity. We are supposed to discuss about social integrity. So when we go down to the bottom, what comes down is the sensory integrity first. Sensory integrity then goes to social integrity. So I was thinking, why not to talk about sensory integration in this platform? Okay. So before talking about sensory integration, we have an OT here and a physiotherapist here. I would just like to share about some of the theories, some of the assumptions. Most of the I saw the researchers of earlier and that believed in the linear integrity model of development. That sensory integrity is very essential. Senses should be integrated. But again, the researchers has come, later researchers after 2015, that believe on linear predictive model rather than the integrity. So there are theories. So predictive model indicate that, I'm just giving the example, it depends on one's perception. So some of the advocates of neurodiversity, they are into sensory integration, some are not into sensory integration because they believe that, for example, let's say that this texture, child is not liking this texture. So maybe it's his perception, it's not the fault of the texture, but what is he predicting? He's predicting that the pencil must be round, but the texture of the pencil is not round. So that's why he might have needed the self-regulation. So one view is that, but still we believe in the eclectic approaches and appreciate the sensory integration approaches, and even our children have benefited that. Still we are integrating that. Again, so now I would like to ask Ganga about the efficacy of sensory integration, how it works, how the sensory integration works. Let's make a discussion of this. And similarly, I would also like to ask Mr. Shamit Kumar Kadila. He's a physiotherapist from NEPTA, and Ganga from ENOT, Occupational Therapy Association. How can a transdisciplinary approach can happen in this sensory integration thing? Is it possible or not? Where transdisciplinary approach in a sense when you are transcending one's discipline. Sometimes even I am an SLP, I might need to transcend my role when across like an educator. So when there are lack of human resources, how could this transdisciplinary approach work when the OTs and PTs work together in sensory integration? I would want to know the thought of both of the members. Thank you.
Thank you. Sensory integration is a framework that was fundamentally developed within occupational therapy by Dr. Jean Ayers, who was an occupational therapist and a neuroscientist. Sensory integration says every sensory input, sensation is the organization by brain for human use. Everything that's coming in, that's sensory input. That's how we make sense of the world, and to organize that for use is sensory integration. Now, sensory integration of an adult and a 7-year-old child, they are similar, which means by the age of 7, a child is supposed to have their sensory integration done, and that happens normally. That happens naturally. Normally is not the correct word. It happens naturally. We don't have to put so much effort in typically developing children. But with children who have developmental delays or conditions like autism, Down syndrome, what happens is sensation that is supposed to be integrated by regular use might be hindered by various comorbidities, the inability of the child to perceive properly. But what is happening? Talking from the fundamental level, everything that is happening in the body is first translated into sensation, and then it develops into higher abilities. Vestibular, tactile, proprioception, interoception, sight, smell, auditory, gustatory, everything forms the basis of a development pyramid, and that forms the foundation for higher level skills. So we cannot say that we can develop perception without sensory integration. So everything needs sensory integration. Sensory integration and reflex integration forms the basis of a child's development. Having said that, sensory integration principles are universal to child development. So as an OT who is trained in iris sensory integration, and the efficacy of sensory integration had always been in doubt because their fidelity measures, the comprehensive assessment were not developed until 2020 when iris sensory integration was officially proven with systematic review that iris sensory integration, not all kind of sensory integration, but only iris sensory integration, and its assessment, intervention, planning is what? Effective sensory integration, not sensory activities or activities similar to giving sensory inputs.
Thank you, Yunga, for making it so clear that it's every sensory integration programs that I've been using everywhere is not our sensory integration program is what Ganga means. So I have the question to Mr. Samit Kumar Karika, what do you expect, how do you expect, and what are your views on the practice of sensory integration?
Thank you, Samit. I agree with whatever Ganga has said. Just to add something about the sensory integrations, when we talk about autism and then when we talk about other disabilities, so sensory system is something that makes us conscious. A person who is in coma, a person who is sleeping most probably has active sensory things, but the input is not there. So one thing what we have to understand is anything that we are learning or experiencing in the world in a conscious mind is a sensory process. It can be visual or something like that. It is very important to understand what is sensory integrations. In a normal individual, sensory system is integrated. I can eat a momo, I can taste it, smell it, somebody can call it momo, somebody can call it dumpling. At the same time, in one sensory system doesn't affect the others. I seeing the momo or I smelling the momo doesn't affect my experience of the momo. When I say momo, I get all the sensory properties of the momo, the color of the momo that I can see, the smell of the momo, the name of the momo that I can hear, something like that. But in conditions like autism, where people may have exaggerated form of sensory preferences, we all have sensory profiling, as Ganga said. Like for example, I am very much, I feel difficult when I hear this sound. Okay, so this can be normal to other individuals, but I feel difficult with this sound only because if I hear it. If I don't hear it or somebody is doing, if I'm not hearing it, I will not have any kind of problem. So this is my sensory preferences that I would not like to hear that, right? So in cases like autism spectrum disorder, the spectrum itself says that in the 4 domains of autism, there can be exaggerated form of sensory preferences or avoiding that, and that will be done by sensory profile. Now, as Savit said that the number of occupational therapists is so less in the country, and the sensory integration is exactly like as Ganga said, the practice, international practice is occupational therapy does that. But when I was working, I started working 2013, and then when there was just starting of COVID time in 19 and 20, the number of cases coming to the clinic autism spectrum disorder were more. I think Ganga first joined into Avani Foundation, and then she was also at NEO, and now she's at Broombrack. So those were the time where the awareness about the occupational therapy was increasing, and then people started feeling that okay, speech language pathology and occupational therapy is one of the major domains that autistic child might need as an early interventions. Technically, physiotherapists do not see autistic case until and unless there are issue with physical comorbid conditions, like autistic child might have cerebral palsy, a Down syndrome child might have autism, like comorbid conditions. So only if it is in spectrum, it is the occupational therapist and the speech therapist that sees. But when there was no human resources, and there are some merging areas of occupational therapies, like not just in autism, but they're in stroke or some other conditions, upper motor functions are done by most of the OTs, in abroad, but the working scopes matches sometimes. So I think the physiotherapists doing sensory integrations was about giving service to the people, and also there were less number of OTs, so I think that was the need of the time.
Can I add something? Now that you asked the question whether or not OTs, PTs, how can they collaborate? So my
in a very concise
yes,
way.
So, everybody needs to be sensory informed, like how everybody needs to be trauma informed now, especially when we are working with children, right? So our sensory integration is available to physical therapists, is available to speech therapists, is also available to psychologists as well. But the difference here is the professional focus and depth, right? As a physical therapist, as a speech language pathologist, as an occupational therapist, we need to understand what sensory integration is, what is the neuroscience, neurophysiology, what are the sensory processing patterns and the adaptive responses that are required. But at the same time, how we translate that into our practice is going to be different, because I cannot do what a PT can do. A PT won't be able to do what I can do or what a SLP can do, right? So the difference is we all can be trained in sensory integration, and it's important that we get trained in sensory integration.
At least that's also explains our diversity. We are talking about neurodiversity. Also we have unity in diversity. That's how our multidisciplinary approach goes. Yes, and what do your remarks, your ending remarks, Anisha, regarding your experience in a very short tone? how you have been, what is your experience in this autism sector? So you are a master in autism from UK. Just in Nepal, just in a few sentences, your workplace and the types of cases, the age group of cases you have been seeing. Just.
In Nepal, yeah, like in our clinic, most of the cases are pediatric, and among them, most of them are again autism with the autism spectrums. Here we have children come with mostly with the question like, when will my child talk? When can they communicate with us? When he can say a word like that? So the main focus is, are they understanding the children or not? Or like, what are their what do you want from the child? How do you want to deal with the child? How do you want us to deal with the child? So like what we do is like to make them understand what is it, what autism is, what the strength your child has, what the child can do with his strength. That's how we deal with the children. Here, like we mostly focus on the child. Child-based approach is used. We used in our clinic, and we also use DR floor time for the childrens. And here we use the play-based approaches and everything.
Thank you, Anisha. Thank you, all the panelists. It was a wonderful time with all the respected panelists. I thank everyone, and bye.
So, since this is autism, I think this will not be complete if you do not take this message. Folinic acid has come as an hope for autistic children, because lots of clinical trial has found that socialization, communication has improved with folinic acid. Is a very cheap supplement, leucovorin. So now I am giving this folinic acid, but actually not to all autism, but we cannot measure this folate antibodies here. So I am giving folinic acid to all autism children. So let's see. This is hope.
I would like to request Mr. Samet Kalkutina to receive the thanks.